Hi, I'm Julien Ginsberg-Peltz. I'm on faculty with the pediatric emergency department at Baystate Medical Center, and I have no disclosures today. Happy to be with you to talk about really sick babies. The original name for this talk was Wicked Sick Babies, but that's very Massachusetts, so we'll make it more appealing broadly. So say you have a case that comes to your ED. This is a baby that kind of scares all of us. It's a 14-day-old girl who's presenting with 6 hours, poor feeding, grunting, kind of sleepy, little mottled skin. On exam, looks stuporous, no respiratory distress, but the vital signs are as such: little tachycardic, blood pressure's low, SATs, the thing's not working, respiratory rate 38, thready pulses, cool legs and arms. What do you want to do with that baby? So you have options. Do you draw cultures? Do you start antibiotics? Do you start acyclovir? Do you begin prostaglandins? Do you give a fluid bolus? Do you want to check a blood sugar? You want to give dextrose if it's low? Or do you want to do all of those things at once? So what does it mean to be really sick? What does that actually mean? And there's lots of categories that you could come up with. It's helpful to have some sense of what really sick means in a baby. The first category here, shock. Shock's a big term, refers to poor organ perfusion. That's one big category we're going to talk about. Second one, cyanosis, or coma. Coma is also a big category, can mean lots of things, but I think everybody would agree that coma in a little baby is a problem. Okay? What's another category? Seizures. Babies with seizures, really different than an older kid with seizures. Last category, blue babies, cyanosis. And again, a big category, but you'll see a fairly straightforward workup. So we're going to kind of bounce around and look at a bunch of these different things. Most of the categories are in the sort of shock area, and then we're going to go through in detail a little bit on cyanosis, on baby coma, and on seizures. And then you'll have an idea of what does it mean to be really sick as a baby, and how might I approach this? So when you think about shocky babies or really sick babies, about half of them are going to be septic. And everybody thinks about that, and we're not going to spend all day talking about that, but sepsis tends to be about half of these kids, and if you were only doing one thing, treating for sepsis is probably the right thing. And you know how to do that. We'll go through a couple things, but you know how to do that. Everything else that you know and that you remember from school or from training is a little less common, but in totality, they make up about half of the other problems. And these are things like congenital heart disease and inborn errors of metabolism and child abuse or systemic viral infections and baby seizures. So there's a whole category of sort of rare and nuance that you have to include to make up that other 50%, which is substantial. So let's talk about the shocky babies first. The shocky babies, big category, and again, about half of these are going to be sepsis presentations. When you think about sepsis, babies, they don't present with a specific presentation. They don't tell you they have a fever. In fact, fever is not reliable, and they might be hypothermic or febrile. And babies don't really localize infections, you remember, so they're not going to just have a pneumonia at the age of 1 week always that sticks in the lungs. It might become bacteremia much more easily. So those are just things to think about with your sepsis workups in babies. What are the organisms? These are things just to remind you of. There's birth canal bugs on the left, and there's community-acquired organisms on the right. The approach is a little different as you get older, but the basic approach is some empiric antibiotics. Your institution will be different. At our institution, ampicillin and gentamicin are often used as broad coverage, and sometimes we'll add more coverage like vancomycin for resistant gram-positive organisms. So without spending too much time on that, remember that not just bacteria cause sepsis, sort of sepsis syndromes can be viral infections too, and in young babies, little babies will present either comatose, really sick, in respiratory failure, febrile, shocky, with systemic viral infections, and these can include things like flu, enterovirus, respiratory syncytial virus in a very young kid can present with just apnea and no respiratory symptoms aside from that. Herpes virus is a big one that we think about in this age, and then people might ask about coronaviruses and other circulating viruses. At least with our novel coronaviruses, little babies aren't having big problems that we're seeing yet. So let's talk a little bit about herpes specifically, because it's one of those viruses that we can treat, and when should we treat it? That's really the question I want you to take home. When should I treat herpes? When should I think about herpes? There's about a couple thousand cases per year in the US in this age group. HSV2, HSV1 is probably a mix of those two things, and it's not so important to know which one. Roots are in utero transmission, birth canal transmission, and also postnatal transmission. But moms, and this is one take-home point to remember, moms are usually asymptomatic. Usually herpes infections that become baby infections are the ones that mom has never seen before, has no antibody protection for, and therefore can pass on to the kid without anybody ever knowing. So when people come to me and say, mom didn't have any HSV lesions, wasn't being treated with Valtrex, that means nothing. In fact, I'm more worried, okay? And that's something to remember. When does HSV present? HSV sepsis and HSV meningoencephalitis that comes from birth or perinatal transmission presents typically in the first few weeks. Most often the first week, but out to about 3 weeks you can see is a possible transmission time, and this is really when you should be thinking about it in terms of this discussion. How does it present? There's a few different presentations. The ones that are easy are the ones that have skin vesicles. Those you can see and should work up aggressively. The CNS stuff looks like meningitis or encephalitis. And then there's also the disseminated herpes infections, which look like shock, pneumonia, DIC. And so any really, really sick baby can be in that disseminated herpes infection. So who should get acyclovir? This is my take-home point on this. Babies who have skin vesicles, that's the easy one. Babies with encephalitis. Sepsis syndrome, but you've had all negative bacterial cultures in your workup. Sepsis syndrome with a parental history. I told you the caveat on that, just remember. And I would say all really sick babies, especially under 3 weeks of age. How do you give acyclovir? You just give it IV, Q8 hours, make sure they're well hydrated. Okay, so that's the herpes discussion. Let's talk a little bit about congenital heart disease, which is something that confuses people and is really hard to kind of characterize and figure out, because you know all these lesions, you know the heart has different sides and problems, but the presentation is really what you're looking at. When I see a kid who presents with shock, for example, I'm thinking about left-sided obstructive lesions, and we'll go into this in a little more detail. When I think about a kid who's cyanotic, part of my cyanosis workup is thinking about right-sided congenital heart lesions. And when I think about heart failure presentations, I'm thinking about left to right shunts. And so these are the three big categories you want to think about as you're working up kids with these presentations who are really sick under 2 months. Okay, so let's go through those in a little detail. You'll notice this diagram has absent chambers. Those are the atria. We don't need those to understand, so we've taken them out. And what we have here is a red left ventricle and a right ventricle that's blue. The big candy cane thing is the aorta. And the blue structure with two leads going out of it is the pulmonary arterial vasculature. And that little purple thing in between is the ductus arteriosus. Okay? The ductus arteriosus can be patent, which it is in utero, and it also can close, which it does and should do over the first week or two, sometimes the first several days or hours even. Okay? So when you have a left-sided obstructive lesion, these are left-sided cardiac lesions. Basically, this picture typifies, say, critical aortic stenosis or an interrupted aortic arch, where you're not getting blood flow out of the left side to the body. What's happening in utero? You are having, the plumbing is working as such that the right side of the heart's providing blood to the body. So because of that, you're getting perfusion to the vital organs until the ductus starts to close. And that happens because of oxygen tension. Baby comes out, looks adorable, people dry them off, they scream, they ah, and all of a sudden their lungs open up, and that oxygen tension causes changes such that the ductus starts to close and they present. How do they present? They present as Shocky, which, as you know, in babies is sometimes hard to know what that is. Vital signs may be important, but shock in babies, they typically look pale. They don't perfuse well. They don't have good cap refill maybe. They look weak. These kinds of things, and subtle, but something to think about. Okay, so how do we identify which lesion it is? Well, that's actually not so important. You know, these things you all learned: hypoplastic left heart, coarctation of the aorta, critical aortic stenosis, and interrupted aortic arch. These are all great to know and remember, but really an echo is going to be the key here eventually. and it's not going to be something you're likely to get done in the ED in that moment. So in the meantime, you're presuming this could be a Shocky baby with a left-sided lesion, and the management is anticipatory prostaglandins, limiting the FiO2, sometimes bicarb or some pressors depending on the situation. And this can be done with some expert opinion. Your job is to consider the diagnosis and to start the initial treatment. This may include prostaglandins, and the thing here is titrating the dose of prostans to the return of perfusion ends up being the important thing. So titrating to femoral pulses is typically what I do, and getting the dose right for that. Okay? People think I have to always intubate these kids because they might become apneic, they might become hypotensive. Again, don't wait to give prostans if this is in your differential. Don't wait to intubate them. You can always stimulate them. You can always support their ventilation in other ways, but intubation sometimes is necessary. So those were the left-sided lesions. They present as shock. Let's stick with the heart, but we're going to look at cyanotic congenital heart presentations. And in that differential, there's a little bit more going on. So with cyanosis, there's other possibilities here. And let's talk about what those are. You know, I mentioned cardiac. Cardiac's a big one. Lungs are a big one. When I say lungs, we're talking about bad pneumonias. We're talking about pulmonary sequestrations and other weird congenital, developmental, embryologic stuff. There's also a couple other things that people don't always think about that in young babies present with cyanosis. So things like very low blood sugar. You can look blue, and you can be cyanotic. Hypocalcemia in young babies, you can be cyanotic. And then weird hemoglobinopathies, typically methemoglobinemia. Something to just remember. This is part of the workup, and it's going to be easy to assess. The workup follows from that differential. So pulse oximetry, is this child who looks blue really blue and desaturated? Typically you need about 4 milligrams per deciliter of deoxygenated hemoglobin to actually look blue, so it's sometimes hard to tell. We do very badly with this, especially in darker skinned individuals. Okay? But working up these other things is easy. Finger stick blood sugar, ionized calcium, where we are doing a co-oximetry, which you're asking, what's the methemoglobin level? What's the carboxyhemoglobin level? Those kinds of things can be done and just added onto your lab workup. Chest x-ray is very helpful here because it looks at heart size, it looks at lung fields, and that can quickly give you an idea of any obvious pathology. Or in the case of congenital heart lesions, it can help you specify what lesion sometimes. Okay? This 100% oxygen thing, that's that hyperoxia test that you learned about a long time ago. How do you do that? Well, you can do it the classic way, which is getting an arterial blood gas while a child is on 100% oxygen. And when you do that, you should see a rise of the PaO2 over 150. Now, in the ED, people are loath to do that or not comfortable with doing that or don't want to do an arterial stick. The sort of cheap way of doing that, the poor man's way of doing that, is to just put the kid on 100% oxygen and see what happens to the set. Okay? And if it goes up, you'd expect that's not a plumbing problem. Okay? The plumbing problem stays a plumbing problem and it doesn't get fixed with oxygen, typically. So that's one way to do that easily, and it's worth doing. In addition, checking oxygen saturations in the arms and legs, checking blood pressures in the arms and legs are easy thing any ER doc can do, and it gives you a lot of information, especially when you're talking to your consultant. So the heart part of cyanosis is just the opposite side of the heart. So instead of not being able to get blood to the body, here we can't get blood to the lungs. Say you have a critical pulmonic stenosis, that's that little hashed out circle there. Basically, the ductus is closing again right after the baby's born, cries, looks adorable, and the ductus closes, so the blood that was coming from the left side of the body, or the left side of the heart rather, going to the lungs is no longer doing that. So a kid looks critically blue. And again, the treatment here is the same. So prostaglandins help to keep that ductus open, and so that's really the management. So which lesion is it? Doesn't matter. Echo's your friend here. Echo will get done. You need to say, listen, this is a cyanotic baby. It's not clearly a lung problem. Sugar was okay. Calcium was okay. It's not methemoglobinemia. This really could be congenital cyanotic heart disease. I need to get an echo, but in the meantime, I need to stabilize this baby and start prostaglandins. So, correcting sugar, correcting calcium, those are all easy things to do. You know the antidote for methemoglobinemia is methylene blue. We're not going to get into details on that, but giving this kid prostaglandins is the key here, and the thing that we don't always recognize when we have a presentation of cyanotic, potentially congenital heart disease. Okay? The third category of heart problem is the left to right-sided shunt lesions. Now these, remember, present a little bit later. It's not a ductal problem. It's not the ductus arteriosus. It's a hole in the heart causing a flow problem. And because of that, you're getting overload to the right side of the heart, which leads to right-sided heart failure. Okay? The typical one here is, and we'll just use this as an illustration, is a ventricular septal defect. So big hole in the heart, which at first may not even be noticed. It might be there's no murmur, there's no sound, the kid looks normal. But what happens over time, as you remember, that baby comes out, cries, looks adorable, and as their lungs start to open up, their pulmonary arterial pressures start to drop. And so this is pulmonary vascular resistance versus age over time. And you'll see that at birth it's very high. It's like the same as your systemic blood pressure. But over time, that starts to drop, and as it goes down, you start to get shunting from a high pressure area, meaning the left side now, to a lower pressure area, meaning the right side. And that's sort of represented by this QP-QS ratio, which initially flow, meaning Q is flow to the lungs and flow to the body, is about the same, 1-to-1 ratio, okay? Over time, as your pulmonary arterial pressures drop, it becomes 2-to-1, 3-to-1, 4-to-1, and now you're hearing a murmur, and now you're getting, every time you pump blood or your heart beats, your right side of your heart's pumping 3-4 times as much blood as the left side of the heart, and it gets fatigued. Okay, and these kids present with heart failure, typically after a month or 2 months or even longer. Okay, there's other lesions that can do this. Ventricular septal defects are the most common one. Patent ductus arteriosus, the duct that doesn't ever close, and an AV canal, which is just a big hole in the center of the heart, can all do this. Okay, how do you stabilize these kids? Well, tolerating a little bit of low sat is important here, meaning you don't want to oversaturate them. You don't want to dilate their pulmonary vasculature, because oxygen is a potent vasodilator here. So tolerate a little bit of low sat, that's okay. A little bit of Lasix, sometimes some afterload reduction. And then these kids don't gain weight, so this ends up being a nutrition problem, which is a longer term problem, not an emergency problem, okay? So again, left-sided heart lesions, shock, right-sided heart lesions, cyanosis, and then shunt lesions, heart failure. Okay, so let's talk about a couple other things that can cause shock in babies, just a couple specific things you got to think about, and just a couple slides on each. So say you have a 3-week-old baby who has been cranky for the past day, not feeding that well, and then threw up a large barf of green stuff. Mom comes in, she says, it was green, it was fluorescent. Well, that should send alarm bells through your brain, and you should be thinking about a malrotation with midgut volvulus. Here's just the reminder. When you have a normally rotated bowel, your bowels in utero go out, twist around, and come back in. And when they do that, they get affixed to the posterior wall of the abdomen so they don't twist again. That's the idea. When you have malrotation, it means that there's no ligamentous fixation, so there's a tendency for the bowel to volve or rotate on its axis, and you get crimping of blood flow, and that can lead to bowel wall edema, ischemic gut, and that's the presentation of vomiting, which is bilious, and that should send alarm bells off, okay? Remember a couple stats on this. This is really important, that 90% of these malrotations volve or twist, if that's a word, under 12 months of age, okay? Most happen in the first month of life, and the sickest ones tend to be the really little ones, the neonates, that group we're talking about here, okay? How do they present? Bilious emesis, abdominal distension, and sometimes shock because they're getting ischemic gut, and that can lead to decompensation. How do you stabilize them? Lots of volume. You want to decompress them with an NG tube. Sometimes it's antibiotics are involved here, and really urgent surgical consultation at the same time as you're getting your imaging studies, which here are in upper GI. So upper GI has to be done in this case. It's not, and again, not done tomorrow, it's done now, okay? One other thing to think about in this age group, and you will see this happens, we're screening a lot more for the common causes of adrenal hyperplasia, but we still see these kids, and this is the way they present. Because they don't have an enzyme that can convert your progesterone into aldosterone and cortisol, these kids present with deficiencies of those things, okay? These most commonly are X-linked recessive, so most commonly boys, and sometimes they present with large genitals because of the hypocortisolemia, low glucose, shock states, which is typically a warm shock, okay? And then low sodium and high potassium, all right? This is just sort of that quick diagram just to remind you of the biochemistry here. The reason you get virilization is because you have a relative over-conversion into adrenal androgens, and you're not making aldosterone and cortisol because of that 21-hydroxylase deficiency, okay? How do you treat these kids? Identifying them. Low sodium, high potassium, low sugar, cold baby, maybe Shocky. This could be CAH. I need to stabilize them. So obviously correcting the sugar, okay, giving them some fluid resuscitation. But the key here is hydrocortisone, which is the correct steroid here because it has some balance between mineralocorticoid to replace aldosterone and glucocorticoid to replace the cortisol. Okay, so just remembering that kid can be Shocky in that category, all right? One other group of Shocky kids, SVT. SVT we talk about a lot, and I don't want to get into the detailed management of this, but I want to talk about why little babies with SVT are a little different than older people, okay? This is virtually the only arrhythmia that affects basically healthy babies and can make them look really sick, okay? It nearly always uses this accessory pathway, which I'll show you in kids under 6 years old, and it can be deadly in the really young kids, and here's the reason. When you're over 6 months old, your sympathetic innervation to your heart is such that you can increase your cardiac output both by increasing heart rate and increasing stroke volume. But with kids under 6 months, really the only thing they can do because of their sort of immature innervation is they can only increase heart rate. And because of that, they get this sort of typical picture where if you look at on the y-axis is heart rate and on the x-axis is cardiac output, you'll see that the kids under 6 months have much less buffer, much less room to increase cardiac output except for heart rate increases, okay? When you get to be over 6 months, Frank Starling kicks in and you get some changes in stroke volume and you can get better cardiac output. But these kids can't, so when their heart's going super, super, super fast, they start to fall off that curve and they can lead to shock states, okay? What are the mechanisms? There's AV reentry tachycardias, AV nodal reentrant tachycardias. It's not really important that you understand all these things in detail. There is some age predominance if you're interested, and so this is sort of the AV reentry tachycardias come like that. The nodal reentry is just within the AV node. These do vary by age, so that the youngest of kids tend to have just AV-RT, AV reentrant accessory pathways, whereas as you get older than 5 or 6 into adulthood, these are nodal reentry tachycardias typically. How do you tell? This goes back to just the basic training around SVT versus a sinus tachycardia, and just reminding you that an SVT doesn't have P waves, it happens suddenly, it's usually a fixed rate, and in young babies they're typically well over 200, usually over 220. Whereas older people into adulthood, this can be in the mid-hundreds and can be an SVT, but not in babies, almost ever. All right, how do you treat it? Again, just reminding you, vagal maneuvers, adenosine, obviously cardioversion, electricity in the youngest of kids if they're unstable. And then we get on to sort of other areas which require some expert consultation. All right, so let's just review the Shocky babies, the kids under a month, one more time. So 50% sepsis, okay? You know how to treat that, AMP, GENT, whatever cocktail of antibiotics you use. Think about gram-positive organisms and resistance in really sick babies. I add vancomycin, okay? In really sick babies, we think about those systemic viral infections that you can treat, and that's herpes, okay? And acyclovir is your friend here. You should give it. Then there's the left-sided lesions, which are leading to pallor, poor perfusion, and that's where prostaglandins come in, keeping the SATs in a reasonable range, tolerating a little bit of desaturation. And then malrotation with midgut volvulus, upper GI, surgical consult, fluid resuscitation. CAH, hydrocortisone, correcting abnormalities and resuscitation, and then the SVT. Okay, so typically these are the Shocky babies. Let's talk about a couple other categories and we'll be done with really sick babies. So comatose babies are the other category I think of. Coma is not good at any age. In this talk, it's particularly bad because it's little babies with coma. And how do you treat coma? Well, oftentimes with coma, we don't know what's going on right away. So oftentimes the first approach with coma is just stabilizing. And this is back to ABCs. This is back to treating the easily treatable stuff. And so with little babies, that's typically correcting low sugar, which can lead to this. That's treating for sepsis potentially, okay? That's thinking about meningitis, okay? Things that you all think about. Considering if you have a baby who's in extremis with coma, considering whether they're in a state where they have impending brain herniation, potentially hyperventilating them, giving them hypertonic saline or mannitol, okay? But working them up after you've stabilized them with head CT and LP is often indicated. There's a couple specific things I want to remind you of, and that is that young children are often the subjects of child abuse, and this is particularly true. This is data that came out many years ago, but still is true, that kids under 12 months who have serious head injuries, about 95% of them are abuse cases, okay? Under 2 years old, a little less, but still very, very high, and that should be high on your differential as you're working up head trauma as part of your coma workup. All right, how do you diagnose these things? This is pretty straightforward. Once you've thought about it, getting head CTs, getting expert consult, maybe getting plain films of all their bone, which we call skeletal surveys where we work, and also getting ophthalmologic exams, etc. Okay, the shaken baby head CTs sometimes present with just diffuse cerebral edema. Sometimes they present with specific bleeds like a subdural hematoma, which you can see here. But again, just to remind you, that's a critical part of the workup. Babies can't tell you a whole lot, so when they're really comatose, neuroimaging is almost always indicated, all right? How do you stabilize them? Stabilizing the airway if necessary. Stabilizing, and preventing seizures, okay? Giving them some fluid resuscitation and monitoring their ICP, okay? There's another category that people get a little bit freaked out about. This is inborn errors of metabolism. I hope I can make this just slightly easier for you, and that is to say the take-home point's going to be think about it, and remember that it's much more common than you think. Some of these are treatable, and the best outcome tends to be early diagnosis and aggressive management. So not as hard as you think. How can we make this easier? Well, kids with disastrous, really bad inborn errors always present under a year old. That's almost always the case. We only worry about the deadly ones, the more subtle ones, the poor weight gain ones, the low sugar after a long fast ones, we don't tend to see and we don't tend to worry about. The bad ones tend to present pretty similarly in terms of the pattern. Okay, so let's just review this real quick. This is what you learned at some point in your life, probably every pathway here. I can't remember the least of this, so I've simplified it just a little bit. Okay, so here's the crude pathophysiology. Basically, you have either too much junk, okay, or not enough energy. And so what we see is two different presenters. The nursery presenters, the babies that present in the office, the babies that present before they even leave the hospital, are the ones who can't make any fuel. And because they can't make any fuel, they have basically total metabolic shutdown and they look really sick. And those are probably not the kids we're going to see. The kids we're going to see are the ED presenters who present with too much junk. They can't get rid of the waste. And so these kids tend to have one of these defects, the beta oxidation defects, urea cycle defects, etc. And so they basically present with a couple different pictures. The CNS part is one and the GI part is the other. The CNS part is kids with low tone. That's real common actually. Kids who have altered mental status. So that's why we're talking about this in the area of coma. Okay. Kids who have seizures. Okay, developmental delay, and then the GI stuff is usually vomiting and transaminitis or liver dysfunction. Okay, so the CNS abnormalities present in about 85% of these kids. Okay, big group of kids, and the GI abnormalities in about almost 60% of these kids. If you see both of these things together, CNS plus GI, okay, that should raise some alarm bells because that in and of itself is much more specific, that pattern. So kid who's really cranky, irritable, hypotonic, and throwing up with transaminitis, that should make you think twice about an inborn error, okay? The most common of these is the organic acidurias and the beta hydroxylation defects. There are a lot of abnormalities, and our job is not really to figure this out, but our job is to do the initial stabilization and to get some labs, and this is what I'd recommend you get. So basic labs that you'd always get, and then add a couple weird things like lactates and ammonia and sometimes blood gases and things like reducing substances and organic amino acids, etc., if you can. So have a little reference card for what you might draw when you think about this, and do it. If you want to take the next step, this is a really nice paper that still holds true from way back when, how to use the labs, and this basically looks at the level of ketones and lactate and ammonia and helps you figure out which possible diagnosis this could be. But that's an advanced move, just something to know about. How do you manage these? Well, you want to stop the kid from eating because we're making too much junk, which is a side product of metabolism. So we want to stop breaking down waste products, okay? And that means telling the baby not to eat, but giving them fluids and some form of dextrose so that they don't get hypoglycemic, okay? Obviously stabilizing the ABCs and then leading on to sort of expert consultation with genetics or a metabolic specialist, okay? So one last category, this is baby seizures. Now, everybody's seen a 15-month-old have a fever and have a febrile seizure, and then they have a popsicle, they run around the emergency department, they go home, okay? That's very different than a 3-week-old with some subtle seizure-like activity. So different age group, really different concern level, all right? And so when we're talking about kids under 30 days, typically we're talking about seizure disorders that either happen as a result of birth injury or something else that's in their metabolism that's presenting really early on. And so most often in the first couple weeks of life, and the incidence is still relatively high, 3 or 4 per 1,000 live births have baby seizures, all right? What type of seizures? Well, there's a few types of seizures that you're not going to see in babies, all right? Generalized tonic-clonic seizures don't happen in babies, and the reason is they don't have fully myelinated mature brains. They can't have a generalized seizure, all right? These focal myoclonic seizures typically don't happen either, so we get rid of those, and sort of thinking about that, it should just remind you that kids don't have a grand mal seizure. They just don't at this age, okay? They have to be really 4, 5, 6 months old before you're going to see that, all right? They might be subtle. They might be a little bit of eye twitching, a little bit of jaw chewing, or a little bit of arm stiffening, but it's not a generalized seizure, all right? The causes, most commonly, hypoxia and ischemia at birth is real common. Head bleeds are common. Some structural abnormalities in the brain are common, as well as infections, etc. Okay? There are metabolic causes like low sugar and low calcium. Those two in particular should always be thought of. And one take-home point and one thing to just remember is that electrolytes are gotten all the time for seizure workups. They're never helpful, ever helpful, never ever helpful in kids that are older than 6 months. But under 6 months, you should get those divalents and those electrolytes, all right? And as far as your evaluation, it includes those things. It might include imaging. It might include looking for infection in the spinal fluid. And later, you can think about all the weird stuff. Okay? The treatment comparisons, this is also a difficult area. We don't always know what we're doing with babies and treating seizures. You know, the non-neonate jerks, looks like a seizure, gets drugs, status, used to be defined as, 30 minutes, 15 minutes. Now we're still defining status as 5 minutes, but that's what status is in an older kid. And you give benzos, you might load them with phosphenitoin or Keppra or something like that. In neonates, they may or may not jerk. They may or may not be having a seizure. We don't quite know what drug to use. So what is status in that kid? We don't really know, okay? And that's just something to remember. It's a little bit of a vague area. What drug order? Benzos might be used, but they're not really proven to be effective in the very young kids. Phenobarbital, phosphenitoin, those are commonly used, and now more and more Keppra as well, okay? So little less clear with young kids. This is just a discussion of phenobarb versus phosphenitoin. I think this discussion goes on and on. It probably doesn't matter which you start with. Giving them some anticonvulsant is probably a good idea. So let's just review kind of the whole scope. Really sick babies, those categories are shock, cyanosis, coma, and baby seizures. Those are the big ones. And so I would encourage you on the coma side to add abuse and inborn errors to your differential when you think about altered mental status in young babies. On the shock side, remember congenital adrenal hyperplasia. Remember bowel malrotation with volvulus, herpes, and those left-sided congenital heart lesions. Cyanosis, quick and easy workup, okay? And seizures, pretty easy workup, but probably avoiding benzos in the young kid is the right idea. So that 14-day-old with 6 hours of poor feeding and grunting and sleepiness, mottled skin and looking crummy, what do you want to do? I'll leave it up to you, but it sounds like you have a plan now, at least how to approach it. And that's the end.
Well, Julien, thank you. That was a great review of what is, for most of us, just an absolutely terrifying topic. And I feel a little bit less terrified than I did before. Can I ask you a couple of quick questions that came to me sort of while listening? So first one was, you mentioned the proper hyperoxia test for that blue infant, that blue neonate. In terms of skipping the ABG and just doing the poor man's version, I sort of think of that's my instinct, is not to be thinking about, while trying to often arrange transfer, coordinate consultants, deal with all the other things going on, maybe even having to do the access in a kid like that, to not have to have an ABG on my list as well, and all the things that go with it, with talking to the family about, I need to stab their artery on top of all this other stuff. What am I losing, though? Because I'll do it if I have to. What am I losing by not getting the ABG and just getting the SAT?
Just specificity, very little, really. And I think that I typically, if I'm working that kid up in the ED, I don't do an ABG. Unless I have all the time in the world and I was working in a nursery and I wanted to, do a series of blood gases. I don't think you add a lot.
Okay,
yeah.
Thank you.
Good question.
The one other question I had, in adult SVT, there's been a big push of late towards calcium channel blockers instead of adenosine. What are your thoughts on that in children?
Older children, there may be some utility for that, and I'm not expert on, I haven't done that yet in older children. We're talking out of the little baby infant age group, not in young kids, not in this age group, this under 2 months. SVT is still a decision tree of, is the kid stable or not stable? If stable, adenosine would be your first line still. If not stable, electricity, but not calcium channel blockers yet.
All right. Well, thank you very, very much.
Thank you.